Thank you, Mr. Chairman, for your kind introduction. Good afternoon, ladies and gentlemen. So in the next 25 minutes, I want you to become familiar with the different imaging appearances of adrenal masses, including pathological relation. And I would like to show you how to differentiate between benign and malignant lesions and show you the value of the different imaging techniques. And last but not least, I want you to understand the impact of imaging given that the patient has or has not a known malignancy. From increased use of imaging techniques, we learned that up to 5% of individuals present with adrenal masses, so-called incidental adrenal lesions. And God thanks, Song and co-workers showed that most of these incidentalomas are benign lesions. However, sometimes adrenal lesions can be functional lesions, and in rare cases there could be the possibility of cancer, either primary or metastatic. If the lesions are functioning, they can cause Cushing's syndrome, Conn's syndrome, Addison disease, adrenal syndromes, especially if there is an overproduction of sex steroid hormones. And when it comes to the practical approach of characterizing adrenal lesions, let me start a little bit unconventionally with a female patient diagnosed with breast cancer. And on a staging CT, a right adrenal mass was diagnosed. So it is of major impact according to the therapeutic approach, if this lesion proves to be a benign lesion or a malignant lesion, or in this patient with underlying lung cancer, if this small right adrenal mass proves to be no metastasis, the primary lesion can be surgically removed and a curative therapy can be performed. However, if this small lesion proves to be a metastasis, the lung lesion now is inoperable and a palliative therapy has to be performed. And we know that up to 50% of adrenal lesions in patients with underlying cancer prove to be of metastatic origin. So how to approach? Well, a good advice from an old radiologist like me is ask always for prior images. If we are lucky and we have got some prior images, either CT or MRI, and if these images show a pre-existing lesions with no increase of size, it's most likely an adenoma. However, if there is an increase in size, think about metastasis. What about morphologic features in incidentalomas? Can size, shape, or heterogeneity be of help? Well, unfortunately, they are usually not helpful. So we do need better tests with higher sensitivity and higher specificity. And we do have these tests because most of adenomas contain a lot of intracytoplasmic lipids, and we can characterize these lipids either by doing density readings on unenhanced CT, including CT histogram analysis techniques, or we can also use chemical shift MRI techniques to prove these lipids. Boland and co-workers showed that using a threshold value of 10 Hounsfield units on unenhanced CT studies, this is associated with a very high sensitivity and specificity in characterizing adrenal adenomas. And this is a straightforward lesion. Another female patient diagnosed with breast cancer. You see on unenhanced CT a right adrenal lesion with 4 Hounsfield units on unenhanced CT. This is clearly indicating an adrenal adenoma, a benign lesion. We can do also chemical shift MRI. In this particular patient with underlying colon cancer, we do the in and opposed phase, and if you see a signal drop on the opposed phase image, this is clearly indicative of an adrenal adenoma. So if we have a drop of signal intensity of at least 25%, this indicates the presence of an adenoma. You can also perform quantitative analysis by calculating the signal intensity index. If this index is below 20, it's most likely a benign lesion, most likely an adenoma. You can also calculate the adrenal to spleen ratio. If it is below 0.7, 7, we are dealing with a benign lesion. Unfortunately, up to 30% of adrenal adenomas remain indeterminate. Why? Because they are lipid poor, and these lipid sensitive techniques do not work. So we need other examinations. Do we have this? Yeah, we have better alternatives, either by calculating CT histograms. We can also perform delayed enhanced series, and we can perform dynamic contrast enhanced imaging. Let me show you an example. This was a patient diagnosed with seminoma, and on the staging CT, on an unenhanced CT, he presented with a right adrenal mass, 31 Hounsfield units on unenhanced. This is not really indicating a benign lesion. So we started to do a CT histogram analysis, and this CT histogram analysis determines negative pixels. That means all pixels within the lesions are calculated within a specific ROI. And by using a 10% threshold value, it has been shown that this technique is very sensitive. It is even more sensitive compared to the use of the 10 Hounsfield units threshold value with the unenhanced CT. And in this particular patient, we did this calculation. We showed that 25% of pixels proved to be of fatty content, and this was indicating a benign lesion, which was proved as an adenoma. What about delayed contrast-enhanced CT? Boland and co-workers showed that malignant lesions, metastases, have a significantly higher density compared to benign lesions or adenomas. And there is a lot of literature. However, there is no unique threshold value. Different authors used different threshold values and also different time windows. And unfortunately, again, with the use of absolute values, there's always the problem with misinterpretation in case of borderline enhancement. These absolute values are also dependent on the different types of CT scanners, on patient factors, on the contrast material use, and even dependent on different delivery rates. So it has been proven that calculating the washout is much more precise and more sensitive and specific. Nowadays, you don't have to keep these formulas in mind, the absolute and relative percentage washout. Just Google, look for absolute and relative percentage washout, and within a few seconds you will get the formulas. You can put in these numbers, and the computer will show you the absolute and relative washout. What you have to know is if the are the figures of the absolute and relative washout. If the absolute washout is above 60%, it's very likely that this lesion is benign, or if the relative washout is above 40%. So these numbers you have to keep in mind. I'd like to show you an example. This was a patient diagnosed with pharyngeal carcinoma, presenting with a large right adrenal lesion, 28 Hounsfield units on unenhanced CT, clearly not indicating a benign lesion. Well, we performed the contrast-enhanced dynamic studies and calculated the absolute washout, and the absolute washout proved to be 81%. That's clearly above 60%, indicating a benign lesion, and also the relative percentage washout with a 46% is clearly above 40%, again indicating a benign lesion, and this proved to be an adrenal adenoma. Unfortunately, this small right adrenal lesion in a patient diagnosed with melanoma, 38 Hounsfield units on unenhanced CT, and an absolute washout of 28% and a relative percentage washout of 17% is not indicating a benign lesion. Unfortunately, this is really indicating the presence of metastasis. And it proved to be a metastasis. If there is no underlying disease, malignant disease, and we have absolute washout and relative washout indicating a malignant lesion, think about a primary arising from the adrenals. In this particular case, it proved to be an adrenal cortical carcinomas. But these are really very, very rare lesions of adrenals. What about dynamic contrast-enhanced MRI? Well, it works similar as with contrast-enhanced CT. We also have to perform a 15 minutes delayed series, and if the washout is above 40%, it's clearly indicating a benign lesion. Comparing a contrast-enhanced CT and contrast-enhanced MRI, what is better? Well, it's comparable. The sensitivity and specificity is equal. However, it's still not 100%. We know that nothing is 100% probably in radiology, but there is still some space to improve our performance. And nowadays there are additional techniques we can use, and this is the PET-CT. How useful is PET-CT? PET-CT combines complementary modalities which allow a precise structural and functional characterization of adrenal lesions. And Poland and co-workers showed that especially FDG PET is very highly sensitive and specific according differentiation between malignant and benign lesions, especially if there is an underlying cancer, and it is not dependent on the imaging device you use. And the good news is also that you can perform the visual analysis. It's not only dependent on calculation of the standard uptake value or the standard uptake ratio. So let me show you an example. This is a patient with an underlying rectal cancer presenting with a small right adrenal mass, and there is clearly an increased uptake of the tracer, FDG tracer, indicating the presence of metastasis. So as a general rule, we can say if the uptake, the tracer uptake, is below the uptake, the tracer uptake in the liver, it's very likely that we are dealing with a benign lesion. If the tracer uptake is equal to the tracer uptake in the liver, it is still probably a benign lesion, most likely a benign lesion. If the tracer uptake is slightly higher than in comparison to the liver, we are dealing with an indeterminate lesion. And if the uptake, the tracer uptake, is higher compared to the tracer uptake in the liver, it's most likely a malignant lesion, a metastasis. And as I already mentioned, Yaghtiani and co-workers also showed that the visual analysis of the tracer uptake is as effective as calculating the standard uptake ratio or the standard uptake value. Let me show you some examples. This is a 70-year-old patient diagnosed with rectal cancer, and on a staging CT, the patient was diagnosed with these bilateral adrenal masses. We did a PET-CT, and PET-CT showed increased tracer uptake, FDG tracer uptake, in both of these adrenal lesions. You see the coronal images here. There's a lot of tracer uptake, especially in the periphery of the lesion, not so much in the necrotic areas. However, this is really indicating the presence of metastasis. And this was proven histologically. This is another patient diagnosed with thyroid cancer, and he had also positive cervical lymph nodes, and additionally he presented with this right adrenal mass. Is it a benign lesion or is it a malignant lesion? This really has another impact according to the therapeutic approach. What do you think? It doesn't really look benign from the conventional CT images. We performed PET-CT, and there was a little bit uptake of tracer, but just a little bit higher than the liver, and it was initially diagnosed as indeterminate. However, it proved to be an adenoma. This was another patient diagnosed with Hodgkin's disease, stadium 3. disease above and below the diaphragm. And additionally, this patient presented with a small right adrenal mass. Is it part of the lymphoma or is it a benign lesion? We did a PET-CT imaging, and this lesion didn't take up any tracer, so we could say this is a benign adrenal lesion, and it proved to be an adenoma. This was another patient with an incidentaloma, so this was a diagnosis by chance. On this left adrenal mass, and it was a small mass. We performed PET-CT, and this lesion showed a really very much increased uptake of the tracer, and this proved to be a malignant disease. It proved to be a lymphoma in this particular patient, a primary non-Hodgkin lymphoma of the left adrenal gland. The patient was underwent therapy, chemotherapy, and in a 4 months follow-up, this lesion has completely disappeared. Unfortunately, there are also some limitations with PET-CT, especially with small lesions, small metastases. There may be a lack of tracer uptake. Another limitation is if the lesion proves to be hemorrhagic or necrotic. And unfortunately, there are also non-FDG-avid primaries, like RCC, renal cell carcinoma, carcinoids, or the bronchoalveolar carcinoma. These primaries do not take up any FDG, and nor do the metastases of these lesions, of course. And there may also be some false positives. There may be some FDG-avid adenomas or hyperplasias. It has also been shown that pheochromocytomas, in very, very rare cases, may show an increased tracer uptake. And also in infectious disease, there is a lot of tracer uptake in adrenal lesions. After surgery or radiation, we see an increased tracer uptake as well. And also, it is well known that brown fat is taking up the FDG tracer. What about diffusion-weighted imaging? Can diffusion-weighted imaging on MRI be helpful in characterizing adrenal lesions? It has been shown by a major study of Miller and co-workers that unfortunately adrenal lesions, that DBI is not very helpful in characterizing adrenal lesions except for adrenal cysts. But it has been shown that especially the ADC values of adrenal cysts differ significantly, but otherwise there is a wide range of ADCs in adrenal adenomas. And there is no significant difference between adenomas and malignant lesions. There is also no significant difference between metastases and adrenal carcinomas. Also no significant difference between malignant lesions and pheochromocytomas and neuroblastomas. No significant difference between lipid-poor and lipid-rich adenomas. So we cannot differentiate between lipid-poor and lipid-rich. And there is no correlation between the percentage signal intensity decrease and the ADC values. So in summary, more or less, it has been shown that the ADCs are not useful in the differentiation between benign and malignant adrenal lesions, and that diffusion-weighted imaging is not proved not to be helpful in differentiation between lipid-poor and lipid-rich adenomas. However, Nicolas Grenier has recently shown, or some years ago, that there may be a value of DBI for the diagnosis of unilateral lymphoma. In summary, I can say that according to the characterization of adrenal lesions, there's probably no test which reaches a monopoly, that a unique test that says, well, that clearly says this is benign or malignant. In some cases, you always need further examinations. Non-contrast CT has been proven to be very effective for characterizing of lipid-rich adenomas. CT washout studies have been shown to be useful, especially in lipid-poor adenomas. And if these figures are clear, then you can stop here. However, despite modern imaging techniques, despite these washout calculations, there will probably remain a minority of lesions which will remain indeterminate. PET-CT can be of tremendous help, especially in patients with underlying cancers. However, a few adrenal lesions will still need biopsy. So thank you very much for your attention.